Uh, Darren Raleigh, Dartford.
Oh, that would okay, okay.
What
Hi,
about yourself?
good afternoon, everyone, and thank you for joining us today. I'm Janelle, Business Development Manager at One Heart Clinic, and we are delighted to host this 45-minute CPD session on practical management of arrhythmias. Today's session will provide a practical approach to diagnosing and managing common arrhythmias and other heart rhythm disorders. We will cover red flag symptoms, key ECG readings, ambulatory rhythm monitoring, and appropriate referral pathways. So we are joined by two excellent speakers today, and we will finish with a Q&A at the end. Please feel free to drop your questions into the Q&A box as we go along, and our speakers will try to address them during the session. Now, I'm delighted to introduce our first speaker, Dr. Sandeep Basavarajaiah. Dr. Basavarajaiah is a consultant cardiologist with extensive experience in diagnosing and managing a broad range of heart conditions, including arrhythmias, coronary artery disease, hypertension, congenital heart disease, and interventional cardiology. Dr. Basavarajaiah, we are delighted to have you with us today. Now over to you. Do you want to start to share your screen now?
Yes. First of all, good afternoon, everyone, and thank you so much for Janelle to set this meeting. And I'm very honored to be part of this webinar. As introduced, my name is Sandeep Basavarajaiah. I'm a cardiologist based in Birmingham. So I work in Heartlands Hospital in the NHS, also Good Hope Hospital, and then I also do private work at One Heart Clinic and Spire Little Aston, and also at the new HCA hospital in Edgbaston. So obviously I've been asked to do some teaching relevant to primary care from the cardiac symptoms and management and cardiac pathology. So I remember I used to give a lot of these talks way back before COVID, and the common topic was always atrial fibrillation and DOACs, because as you know, the DOAC was not on the generic, and they used to sponsor lots and lots of meetings. And I used to remember whenever I used to go to any GP surgery, the moment I say AF and DOAC, they were saying no fucking way. So then obviously, it was not one of those pleasant experiences because you're always talking about DOAC. Okay, so now I'm thinking to go something more different. So maybe some common cardiac symptoms which are encountered by the primary care physicians and how to deal with them. So what are the current issues in both primary and secondary healthcare? Obviously, we're still feeling the effects of COVID-19, which has affected both primary care and secondary care. You all know there's a super long waiting lists in the outpatient clinics. Waiting lists could be up to a year in some hospitals, maybe even more than that. And also there's a significant investigation on treatment delays. So which is why I think, the strikes are also not helping, although they have now come to some kind of compromise. So hopefully this may change in the future, but still we have to address all these other issues in regards to waiting list in the secondary care. I'll go through 4 common symptoms you will encounter in the primary care. So chest pain, shortness of breath, syncope, and palpitations. My colleague will be covering palpitations, so I will dwell little on it. So let's start with the chest pain. So when someone comes with chest pain, obviously the main worry is whether it's angina. And of course, we have 2 kinds of angina. One is stable angina, which is described as patient having chest pain on physical activities and resolving completely at rest. Whereas unstable angina, patient having chest pain at rest or minimal exertion, or even having a crescendo nature in the sense, let's say a month ago, they were getting pain on going up the hill, but now they're getting pain on doing daily activities or minimal exertion. For me, that is a crescendo angina. In fact, I would kind of classify more as unstable angina. So obviously unstable angina, you send patients straight to the hospital to emergency. So, if someone is having pain at rest or minimal exertion, you ask them to go to A&E or go through the medical assessment unit. But stable angina is something which can be managed in the primary care to start with. And of course, they need investigation and assessment in the secondary care. But there are a few things that could be done in the primary care to help patient. As I said, stable angina, the definition is chest pain on exertion settling with rest and/or GTN spray. It's a clinical diagnosis. And of course, we do tests to confirm the cause for angina, which includes an echocardiogram and an angiogram and things like that. As I said, beware of crescendo symptoms, because although the definition of stable angina is pain on exertion settling with rest, as I said, if a patient who was having a symptom on exertion 2-3 months ago, now getting on mild exertion, for me, that is a crescendo symptoms, and those patients have to be either expedited for an urgent referral or even sent to A&E. Also be aware of the atypical presentations, especially diabetics and elderly patients. They may not have a classic exertional chest pain. They may report exertional breathlessness, and you do a BNP, which is normal. And then, of course, it could be, and if they don't have any documented respiratory illness or asthma, exertional breathlessness with normal BNP in patients who have diabetes, I always think that could be a ischemia presenting as breathlessness rather than chest pain. The common cause of angina is coronary disease. Of course, you have other conditions like aortic stenosis, cardiomyopathy, microvascular angina, and vasospastic angina can also cause chest pain, but coronary disease is by far the most common. Let me start with a case. So 54-year-old man with exertional chest pain, usual risk factors, hypertension, family history, and smoker. And his ECG was normal, which is what we see in most stable angina patients. The resting ECG is usually normal. And obviously, what next? Yes, you're going to refer this patient to cardiology, but while he's waiting to be seen by the cardiologist, which could be up to 6 months or a year, I think consider some pharmacotherapy, which is very, very important. So make sure they go on aspirin or clopidogrel, statin, and anti-anginals under GTN spray. Now, anti-anginals, obviously, we've got variety of it. I mean, the commonly used is beta blocker, which I think it's fine. But one of the limitations of beta blocker is the patient tolerability, because they start having side effects like getting tired, because of the bradycardia. Then you can try calcium channel blockers. My favorite is diltiazem. It's quite well tolerated. Oral nitrates is great, but a lot of patients get headache with nitrates. Nicorandil can also be tried. Again, there are some side effects like ulcers, especially anal and mouth ulcers can be an issue. But for me, one of the favorite is ranolazine, which is relatively well tolerated, can be used in most patients. Of course, patients if they have a severe renal impairment, you can't use it. But otherwise, it's one of the best drug, well tolerated, very little effect on blood pressure and the heart rate. And of course, you can also consider ivermectin. So, I mean, you can go any of it, but I understand in the primary care, ranolazine is probably expensive. I totally understand. I think worth trying something more simple like diltiazem or a beta blocker, then you can go to ranolazine or nitrates. In the secondary care, obviously, we do investigate these patients. So if you have something, 86-year-old with angina, we try to manage them medically. But younger patients, we tend to find out more definite diagnosis by doing an angiogram and an echocardiogram. So this is the same patient I told you. He came in with angina, so he had an angiogram. You could see there's a stenosis in the LAD. So this is the catheter sitting in the aorta, injecting the dye. So this is your LAD, and you could clearly see there's a stenosis in the mid segment. And the next step, of course, you could go for medical therapy. We do angioplasty with stents or bypass surgery. But obviously, we discuss most of these cases in our heart team meeting and offer treatment based on patient's risk profile. When we do angioplasty or any form of revascularization, even with coronary bypass surgery, we are doing it for either prognostic benefit or symptomatic benefit. If someone has a triple vessel disease, like here, for example, this patient has severe disease in the left main stem involving circumflex and the LAD and also right coronary. These patients are generally offered coronary bypass surgery as a first choice. But of course, if patients have severe kidney impairment, or if they've had previous stroke or comorbidities, then we end up doing angioplasty for these patients because their surgical risk is high. Angioplasty, obviously, I'll go very quickly, couple of slides. We don't use any more bare metal stents. We use drug-eluting stents, which is very popular, which are coated with a drug, especially paclitaxel and sirolimus. And these days, we're also using drug-coated balloons. You may have seen some of our letters coming saying this patient had a drug-coated balloon. The rationale is that we want to avoid metal in certain patients, which forms a nidus for future stent-related events. So we use drug-coated balloon. Basically, these balloons are coated with anti-proliferative drug like paclitaxel or sirolimus. and we inflate the balloon in the artery for 1 minute, and the drug goes into the artery, and we take the balloon out. So there'll be nothing left behind other than the drug, which will be gone in 2 or 3 months. So this is something which is evolving, and you will see more and more of this being used in angioplasty. So in this case, we put a stent in. So this is a stent. You could see it being positioned in the LAD. And after stent, you could see the stent expanded and the artery has been treated and patient became asymptomatic. This is to show pre, and this is post. Post-angioplasty, as you probably know, patients should be on lifelong aspirin or clopidogrel. And these days, we're using some of the newer antiplatelet like prasugrel or ticagrelor, especially in some acute coronary syndrome and complex patients. We normally give it for 6 to 12 months. I tend to give for 12 months, especially in complex patients, but current ESC guidelines say 6 months, so you can stop at 6 months. If you're using drug-coated balloon, the advantage of drug-coated balloon is that you don't have to give them longer duration of DAPT, I mean, dual antiplatelet therapy. You could give as low as a month, sometimes up to 3 months. The beauty of DCB is that because you're not leaving anything behind, you can cut down the duration of dual antiplatelet therapy. After 1 year, you have to continue one antiplatelet for lifelong. It could be aspirin or clopidogrel based on patient's tolerance. Acute coronary syndrome, I'm not going to dwell much. Essentially, STEMI, ST elevation, immediate angiography, and stents. In STEMI, we admit them, we offer them angioplasty, angiogram sort of 2 to 3 days later. Thrombolysis, we don't do anymore. This is just a case of acute MI, which was opened, and we placed a stent, and we opened the artery. The post-ACI is the same thing. We give aspirin and clopidogrel or these newer antiplatelets for a year. And also we put them on ACE inhibitor, beta blocker, and statin. And of course, these patients will undergo cardiac rehab for at least 6 weeks. Sometimes we encounter patients who may have a thrombus in the left ventricle. So this is a left ventricle. You could see a thrombus there, especially patients with a big anterior myocardial infarction. They may be left with a thrombus in the ventricle, and in which case we'll have to give them anticoagulation with warfarin. Or sometimes patient may have a pre-existing atrial fibrillation, so they already are on DOAC or warfarin. And if they have angioplasty, what do we do? So we have something called a triple therapy, which means you give them aspirin, you give them clopidogrel, and you give them anticoagulant. Now, we do triple therapy for a week. It's default. But if patients have a high bleeding risk, so someone is elderly with low hemoglobin or previous bleeding, we only give dual therapy, which means we give DOAC with either aspirin or clopidogrel. If sometimes we find a high ischemic risk, so patient with a severe coronary disease, complex calcium, thrombus, we want to give triple therapy for up to a month. It's allowed. So it could be 1 week, it could be 1 month, but it could be just dual antiplatelet therapy. So I think this will be usually clarified in the discharge letter for patients, or it could also be in the letter dictated by the cardiologist. Now, after 1 year, what happens in ACS patients? The ESC guideline says you can stop the antiplatelet and only leave them on anticoagulant. Now, this is fine for patients who have high bleeding risk, but my concern, and I'll give you a case example, this happened in our center last year. Patient had a stent 4 years ago, was on DOAC and obviously aspirin, and after 1 year, aspirin was stopped. Patient was on DOAC. Now, last year, he was listed for an operation, and they stopped the DOAC for almost 2 weeks. So patient had no DOAC, no aspirin for 2 weeks, and he had a stent in the left main, which blocked off, and patient died. So now we tend to leave at least one antiplatelet lifelong, because if something were to be interrupted, like anticoagulant for an operation or for some other reason, patient has some protection with aspirin or clopidogrel. Any questions before I go to my next section? Let me see what's in the Q&A.
Yes, there is one question in the Q&A box.
Okay, let me just open that. Q&A. Okay. Why not thrombolysis anymore? Okay, so thrombolysis is out of fashion because it's very unpredictable in terms of the response, because you're giving a drug expecting it to thrombolize or lyse the clot. So that we can't expect a predictable response to the thrombolysis. And there are enough evidence in the literature to suggest that primary angioplasty, which is basically taking the patient into the cath lab and opening an artery, is far more superior than thrombolysis. Having said that, there are certain places that are still using thrombolysis. So, for example, I was in New Zealand recently on a meeting. In south of New Zealand, they live in these fjords, which takes long time for patient to get to the hospital. So if the patient journeys anywhere between 90 minutes to 2 hours to the hospital or anything longer, thrombolysis is recommended. And someone has said, can you go a little slow, please? So sorry for that. Yes, I was rushing a little bit. Yes, I will go slowly for the next section. But for this section, do you have any other questions?
No, it's all good for now. Just go on, please.
Okay, so I'll keep it open for the questions. So please feel free to answer. Ask me any question for the next section. Okay, so the next is the breathlessness. Okay. So breathlessness is another symptom, which again kind of tilt towards more heart failure. And of course, in the primary care, you all do BNP levels, which is an excellent negative predictor for heart failure. And in the primary care, you do ECG. Chest X-ray can also be requested in the primary care. But of course, some places have an open access echocardiogram, so GPs can request a heart scan. But some places it has to be requested through the cardiac department. So this is what happens in Heartlands. In Heartlands area, GPs cannot directly request an echocardiogram. It has to go through the cardiologist. Whereas I work in the other hospital in Litchfield, where GPs can directly request an echocardiogram. So these three tests can be done in the primary care and the echocardiogram in the secondary care. Symptoms are heart failure. Breathlessness is a predominant symptom, but they'll also have congestion. It could be in the lungs. Patients are breathless at rest. They could have a lower saturation. If you observe the JVP, it can be raised. And of course, they could also develop pitting edema in the legs, especially in chronic heart failure patients. And we do NYHA functional class. So if someone is in NYHA functional class 3 or 4, which basically means you're breathless at rest or minimal exertion, those patients have to be admitted to hospital for further treatment. Whereas if they have NYHA functional class 1 or 2, which means you get breathlessness on exertion, they can be managed in the primary care to start with and a referral to the secondary care as an outpatient. NYHA class, as I said, you got 4 class, and this is an excellent classification which can dictate how the patient can be managed. As I said, 3 and 4 hospital admission, 1 and 2 can be managed in the primary care. For heart failure, I mean, medications are very important, but I think there are general measures are as important as medications. Of course, weight loss, low salt diet, fluid restriction, especially if they have a documented LV dysfunction, smoking cessation, usual vaccination, and alcohol consumption has to be curtailed. Pharmacotherapy, we give beta blocker, ACE inhibitor, SGLT2, so the dapagliflozin or empagliflozin. So these 3 can be started in the primary care. Whereas aldosterone antagonists like spironolactone or eplerenone, or further more complex ones like Entresto, should be in the secondary care. But these 3 medications can be started in the primary care, and I think it is worth starting them on, let's say, 2.5 beta blocker. But I think up titrating can be done in the primary care while they wait to see us, because if you give them small dose of these medications, that may not make them any better till they see us. But if you can control by increasing these medications, that will have a massive impact on patient symptoms. Diuretics, again, can be given in the primary care, and it's mainly for symptoms. The goal of diuretics is to be completely stopped once they are established on these medications. So diuretics are given in the early phase, but as patient goes on these more complex medications, they should come off diuretics as it has got no prognostic benefit other than some symptom benefit. Any questions on the heart failure? Let's see what we have. Okay, no questions on the heart failure. Okay, so then let's go back to syncope. I think this is one of the most important symptom which needs thorough evaluation, again, in the primary care. So when someone comes with a syncope, the first thing is to establish what was the syncope, because if you ask some of the elderly patients, they say, oh, I collapsed. And the collapse is a very vague term. If you ask them, did you lose consciousness? A lot of them said, no, I didn't. I just fell on the floor. So that is not a syncope. So history is very vital. And the other most important is to ask them, did they have any time, any prodromal symptoms, or it happened immediately? So unheralded syncope means they have got no warning symptoms, they just faint. And this is a malignant symptom. Generally mean they have some kind of underlying arrhythmia, could be bradyarrhythmia or could be tachyarrhythmias. Whereas if they get more warning symptoms like feeling sweaty, unwell, and then they faint, they generally point towards vasovagal syncope, and that's usually seen in younger patients. So history will give us an idea what kind of syncope they have. So if they have unheralded syncope, if they're elderly patients, generally it's a bradyarrhythmia, or it could be aortic stenosis. So worth auscultating. If there's a murmur, those patients should be expedited for an urgent scan. As I said, sinister features, elderly patients having syncope is generally means that they have some problem with the rhythm. Unheralded syncope, as I said, without any warning, generally is a cardiac syncope. Exercise-induced syncope, especially elderly, younger patients, could suggest to us either an underlying cardiomyopathy, or it also could be an arrhythmia. So anyone blacking out while they're on the treadmill or exercising, they need an urgent evaluation. Again, if you do an ECG, if you have an access to that ECG, that will be helpful, because if it shows bundle branch block or a first degree AV block, especially elderly patients, it suggests that they may have underlying conduction abnormalities. If they have a right bundle branch block or a trifascicular block, it's clear that they probably have something underlying sinister. Just to show an ECG, so this is an ECG which shows marked first degree AV block. You could see a PR interval is 356. This is a marked first degree AV block in an elderly patient with a heart rate of 54, not on any beta blocker. If this patient comes with syncope, it's almost likely this patient have an underlying heart block, which causes syncope. This is another ECG showing trifascicular block. You see this as right bundle branch block, left axis deviation, and a first degree AV block, which is PR interval 316. As you know, the cutoff is 200 milliseconds. So this is right bundle branch block, left axis deviation, and first degree AV block. This is a trifascicular block. If we do encounter patients with trifascicular block with syncope, we don't even look for heart block, we give them pacemaker. This is another ECG showing left bundle branch block. You could see this is a prolonged Hur's complex. And again, the heart rate is 42, so there is sinus bradycardia. So these patients generally tend to have underlying conduction problems. I won't go into this. This is basically a 2:1 heart block. You could see here there's a P wave there, followed by a Hur's complex. And then you have a T wave here, and you have another P wave, but no Hur's complex. Then it comes back. So every second P wave is not conducted. This is a 2:1 heart block. Now, this is a patient who came with a syncope, young patient, football player. He fainted while he was in the football pitch. And when we did the ECG, he had this deep T wave inversion in the lateral leads and some SSM depression. This is a very abnormal ECG, suggestive of underlying hypertrophic cardiomyopathy. So this is a kind of patient, if they have syncope, they need an urgent evaluation. Investigation for syncope, we do Holter, could be 24 hours, could be 48, 72, or 7-day ECG. In the private practice, we tend to have what we call a Zio patch, which can be left for 2 to 3 weeks, which is a better long-term recording for patients. This is a recording showing a pause of on an ECG. So you could see here there's no activity at all, and patient then gets an activity. So this basically is where patient had a pause and fainted. We also do an event recorder. So this is mainly for palpitations, where patient have a button to activate when they feel symptoms. For the unheralded syncope, you can't expect patient to activate because they'll not have any time. We use this especially in syncope patient, implantable loop recorder, also called as reveal device. So this is a little device. We put it under the column bone, under the skin, and that can be left for 2 to 3 years, and it will record any abnormal heart rhythms because it's programmed such a way that any extremes of heart rate, so if the heart rate drops to less than 30, or if it goes then more than 150 or 200, it will automatically send a message to the cardiac department so we can follow up the patient with symptoms. Equally, patient can also activate it. So for example, if they feel faint or they feel near faint, they can activate it, which means it records the rhythm and sends it across. So it's one of the great devices we use, especially in patients with syncope. And this is how the reveal device looks like. This is a very tiny device. It's placed under the collarbone, under the clavicle. So in the primary care, patients with syncope, obviously, if they're on rate-lowering drugs and if the heart rate's on the lower side, I think you can at least reduce it or stop it. Polypharmacy is something, especially if they have multiple medications that can cause hypertension, you can try and reduce that. You can access an ECG, which is very good because if you have an ECG and if you're not sure about the recording or the findings, you can send the ECG to us for us to see. And if we do find something like a heart block, then we obviously expedite the appointment. But if it's something reassuring, we say it's normal, but we'll see the patient. Palpitation, I think I'll skip this because my colleague's going to cover that. But very quickly, again, palpitations, history is vital. Most of them are benign, especially if it's infrequent. When I say history is vital, I always ask the patient, what do they describe? What do they feel when they say palpitation? Is it a skip beat or they feel the heart is racing? A lot of the time, it's very easy. Ask them to tap it on the table when they're seeing you in the clinic. When they tap, you will know what the palpitation is like. If they tap it like fast heartbeat, then you know it's some kind of tachyarrhythmias. But if they tap it more like a missed beat, you know generally it's an ectopic beat. I'll skip this. Causes of palpitations are, as I said, ectopic beats. You could have atrial fibrillation. You could have some kind of tachyarrhythmias like SVT or ventricular arrhythmias. Sometimes sinus tachycardia can also cause palpitations, which can be picked up on an ECG. A sinister features of palpitations, as I said, if the palpitation is associated with syncope or chest pain, or if they get exercise-induced palpitations, especially younger patients, then it's a sinister feature of a malignant arrhythmia. And also, if they have underlying LV dysfunction, and if they come with palpitations, maybe they're having some significant tachyarrhythmias like atrial fibrillation or could be ventricular arrhythmias. So history is very important that you can elicit in the primary care. ECG, you can get an access to it. You can also start treatment if patients have ectopic beats or fast heart rate. You could give them some beta blocker, and you could also request a heart monitor in the primary care. So in conclusion, I've discussed some of the commonly encountered symptoms in the primary care and how to suspect whether they have angina, heart failure, arrhythmias based on the symptoms, and how much can be done in the primary care whilst patients being referred to secondary care, especially in the current climate where we have to wait longer for patients being in the secondary care due to various pressures. So some patients may not need referral to secondary care. For example, if you ascertain the palpitation is not benign, and if it settles with reassurance or with medications, they can simply be reassured. Thank you so much.
Thank you, Dr. Basavaraj, for those valuable insights. Now it's my pleasure to introduce our second speaker, Dr. Vrijraj Rathod. Dr. Rathod is a highly trained electrophysiologist and consultant cardiologist, treating patients with heart rhythm disturbances at Barts Hospital and Dartford and Gravesend NHS Trust. He obtained his medical degree from Imperial College with multiple academic merits. Dr. Rathod, thank you for joining us today. I will hand over to you now.
All right, thanks for giving me this opportunity. And just give me a second. I'm hoping you can see the slides. Can everyone hear me and see the slides? Yeah. Yeah.
Yes.
Yeah. Okay. All right. So look, this is my way of approaching palpitations. It's very similar to my previous colleague, and it's the way I think you can utilize the current technology that everyone has in hand. So I'm just going to talk about our One Heart Clinic pathway, the palpitations and atrial fibrillation. So the One Heart Clinic approach is when someone comes in, our team, very comprehensive, does a few investigations and is triaged to the appropriate consultant who does a comprehensive assessments and looks at all the information available. This approach enables us to have the information before we actually see the patient, and so we can make have all the evidence there to make a diagnosis. It just enables us to give it like a one-stop approach. Majority of our patients are discharged after the initial assessments. Either they're reassured the symptoms are benign, or they are given a diagnosis and what the other medical approaches could be, or invasive approaches, which I'll talk about later. And so that's this One Heart Clinic pathway that we have. So in terms of history, as my colleague said, the history will tell you the diagnosis really, and 80% of diagnoses are given by history. So the one is, how frequently are the symptoms? So do you get it once a week, once a month? If you're going to get a symptom once a month, it's futile to do a 24-hour monitor or a 7-day monitor. It's just the yield's going to be extremely poor. And how long do the symptoms last for? So if they're very short, if they're a few beats or like a skip beat, it's probably going to be something like supraventricular ectopic beat or like premature complex, just the additional beat. If there are sustained and for longer periods of time, it could be a supraventricular tachycardia or VT. And it's sometimes harder to differentiate between them. If it's regular or irregular, irregular suggests it's atrial fibrillation or supraventricular ectopic beats or premature ventricular complexes. If it's regular and sustained, it's probably an SVT. And what the provoking factors is, it exercise is provoked by alcohol, or there's a history of substance abuse, and then you do an examination. And so murmurs can something like mitral valve disease. It's commonly associated with atrial fibrillation, so you just need to make sure you eliminate that as a cause, and just look at the thyroid status. So are they thin? Can you see a goiter? And just to kind of give you a hint of what you're assessing. And then so basic investigations, we do a thyroid function test, and we check the hemoglobin. And then you do a resting ECG just to see if there's any pre-excitation, so any delta waves that might be suggesting there's an underlying associated pathway. And then we talk about ambulatory ECG. So if the symptoms are very frequent, let's say once a day or once every 2 days, you can do a 40-hour Holter monitor. If they're very frequent, like as in once a week, you can do a 7-day monitor. And then I do an echo, and the echoes are going to look at mitral valve disease. Patients with hypertrophic cardiomyopathy are predisposed to atrial fibrillation. I look for any other structural abnormalities like an ASD or LV impairment, which can sometimes provoke ventricular arrhythmia. So you kind of eliminate what other causes there can be. And so ambulatory findings, I see this quite frequently observed. So non-sustained SVT episodes, which do not correspond to any symptoms, are kind of irrelevant. So I get saying, oh, this patient's had 8 beats of an SVT. How relevant is that? It's probably irrelevant, actually. You don't need to investigate that any further. And low burden of SVEs or ventricular ectopic beats, anything less than 5%, doesn't need to be investigated. You can do an echo in the community, just rule out any structural abnormalities. But anything more than 5%, that's when we get interested in doing further investigations. And so when I refer a patient for an ambulatory monitoring, I emphasize the need to keep an accurate diary. So you want to correlate the symptoms to an ECG. So patients say, "Oh, I get palpitations," but if the symptoms correspond to sinus rhythm, you can just reassure them, "Look, when you had symptoms, it was a normal rhythm. So whatever you're experiencing is genuine, but it's not corresponding to an abnormal ECG or an abnormal symptom." And that kind of reassures them, and the symptoms kind of disappear after they're reassured. Now, this is when I was talking about what we should use our technology. So Apple Watches is a great tool, it has a great sensitivity. It's not as specific. So what I say is that if the watch tells the patient that it's got atrial fibrillation, the newer watches let you capture an ECG. So do an ECG. So this ECG from our patient, you can say it's irregular and they're on a P wave. So even though the watch sometimes says it's F, it might not be F. So I always encourage them to do an ECG. And the other thing that this tool is the Cardia mobile device, which is on the top right-hand corner. And it lets them capture an ECG themselves. There's two forms. One's a single lead, and the other is a 6 lead. And it lets you capture an ECG. If they have this, it tells you what the diagnosis is. And from that point, you can discuss the management. The management could just be do nothing because it's a benign condition, or we can introduce tablets, or we can do something invasive. That's what we offer at our institute at Barts and the private sector. We can do something called an ablation, where you pass a few wires into the heart and find out, locate where the abnormality is and try to get rid of it. But the key issue here is that you need objective evidence that they've actually got this condition. And is it that actually when they get symptoms, it's just the sinus tachycardia, or is it a narrow complex tachycardia, an SVT? So I'm just going to talk about atrial fibrillation. My colleagues covered some of this. One of the most commonest arrhythmias that I see is highly prevalent in the 70s, in people in the 70s and 80s. And the definition is no discernible P wave with an irregular R interval. So I sometimes get query, "Oh, there's a P wave here. There's a P wave here." But you see the P wave morphology is not consistent. It's irregular and it's really rapid. So no clear P wave and an irregular heart rate going rapidly suggests that this is atrial fibrillation. The clear cut is look at V1. If there's an irregular multiple morphology P waves in V1, that tells you the diagnosis that this is atrial fibrillation. So atrial fibrillation has an ABC approach, and this is a hierarchy in the sense that the most paramount action to undertake is A, anticoagulation. So you look at the CHADS VAS score now, the gender's not taken into consideration, or because it was confusing, because if you had 1 point for female, it wasn't taken into consideration. So they've just eliminated that now. So sex is no longer attributed as a risk factor. So look at congestive heart failure, look at hypertension, look at their age, if they're diabetic, if they've had a stroke before, and if they had vascular disease. So my approach is, if your CHADS VAS score is 0, you don't get anticoagulation because your risk of bleeding is higher than the benefits from taking DOACs. If your risk is 1, you have a 1% risk of a stroke every year. That risk accumulates, so over time it will get up, it will increase. So I normally say I should advise them to take anticoagulation. It's more likely to be beneficial than harmful, but the benefit is smaller than someone with a CHADS VAS 3 or 4. And so anyone 2 and above, independent of what gender they are, gets anticoagulated. And I would highly recommend that. And I think my colleagues covered this already, so I won't dwell too much, but it's about triple therapy. In the long term, we do advise patients to be on a single agent, which could be a DOAC, with emphasis that they cannot stop the DOAC unless they have antiplatelet cover. So even for a day or so, or 2 days, I don't stop it if they've had previous coronary intervention. But initially they get triple therapy if they've had an acute coronary syndrome, or if they've had an elective stent. And this is based on the ESC guidelines. There's been 3 trials which have shown, 3 trials recently which have shown that patients who tend to be on DOACs and antiplatelets for long term, they tend to have a higher risk of bleeding. It's a cumulative risk. So the patients with atrial fibrillation, how to manage them, the control, the symptom control. It's more to do with if they're suitable for an ablation. So the patients who are young, who have LV impairment, who have symptoms, significant symptoms, should be for an ablation. And so the reason why we want to see these patients earlier is that the earlier we see them, the more likely we're going to stay in normal rhythm. So if they're in the paroxysmal state, that means they're going in and out from it. They're more amenable to an ablation, so more likely to stay in normal rhythm. The more you stay in the persistent or permanent state, the more changes you're going to have in the left atrium. What that means is that it's more challenging to get them in normal rhythm because it's not the pulmonary veins which are causing the substrate, the other bits that are provoking these episodes. So what do we do? The target heart rate. This is the New England Journal of Medicine lenient versus strict control. Patients with a heart rate of less than 110 have the same outcomes as a heart rate of less than 90. So I normally say your target heart rate, atrial fibrillation, should be less than a heart rate of 110. You don't need to be too aggressive. The reason for that, if you're too aggressive, that could be detrimental to their health, especially if they're elderly. And so the outcomes were saying this group, they had a resting ECG. The patients who were in aggressive control, they had exercise ECGs. But I would say a resting ECG which shows a heart rate less than 110 beats per minute is perfectly satisfactory. So why do I advocate for AF ablations with patients with heart failure? This was a Castle AF trial. Anyone who has persistent AF, well, to be honest, new onset of AF with LV impairment should be referred for an AF ablation because there's data to prove that the procedure itself will reduce mortality and reduce hospitalization. And so how do we do this? So the way we do it under general anesthetic, pass a couple of wires into your heart, and we use a needle and cross from the right atrium to the left side, and we use a catheter, and we create a shell of the right atrium, and then we use an ablation catheter, and we electrically isolate the pulmonary veins. What this is not a curative procedure, but it will reduce the burden of AF, all right? So paroxysmal, reduce the burden of AF. And there's newer technology out there. Well, this isn't new anymore, but it's cryo-AF ablation, where we use a freezing balloon technology to freeze the pulmonary veins. The veins are still patent, but they're electrically isolated. So the current inside the veins, which we think is provoking the atrial fibrillation, is diminished. And so we go from the right side of the heart, punch our hole, and go to the left side of the heart with the sheath, okay? So this is cryo-AF ablation. And what cryo-AF ablation has shown, it's superior to medical therapy. So if you did medical therapy compared to cryo, the patients who had cryoablation had fewer episodes of atrial fibrillation. They weren't taking the antiarrhythmic medication, and it delayed the progression from paroxysmal to persistent AF. This is geotechnology, pulse width ablation, where we use sharp electrical bursts of electrical energy to diminish atrial activity in the left pulmonary veins. The reason why this is being promoted so aggressively, it's electric myocyte selective. That means it doesn't damage other organs in the heart, so it's protective. It doesn't damage the esophagus, and it's rapid. You can do this procedure within 30 minutes. Some there asleep. And so this is shown data in persistent AF compared to antiarrhythmic medication. There's fewer number of episodes with with this pulse wave AF ablation. For patients who have AF ablations who are paroxysmal, we want to see them because it's a treatable condition. If they have had persistent AF with LV impairment, we would see them because we can reduce the burden of AF and we can improve the heart function. And that's end of my talk. Sorry, that was a bit quick. I was restricting time. Does anyone have any questions?
Yes, there are 2 questions in the Q&A box.
Bear with me. I'm just gonna open up the Q&A box. Okay. So one question is, are there any watches that show ECG? Yeah, so the Apple Watch enables you to capture an ECG when you're getting symptoms. It's only a single ECG, but it does do it. And the diagnosis at the top may not be accurate, but what it does is it gives you objective evidence where you can show another physician, look, when I had symptoms, this is what the ECG was. And you can see, oh, was it sinus rhythm? Was the atrial fibrillation? Blood pressure machines tend not to be accurate in terms of if there is an irregular heart rhythm or not, but ECGs, Apple Watches, and cardio devices are a great tool. Does that answer your question? I'm hoping. Any other questions?
And the first one, I think Dr. Basavarajaiah haven't replied to it. So what was the footballer's ECG?
Dr. Bessa, from my impression, that showed a hypertrophic cardiomyopathy. So you saw the deep T of inversion and lateral leads. The big R wave is consistent with HOCM. I don't know what the final diagnosis there was.
Okay. I think that's all the questions we have now. And thank you very much, Dr. Rathod, for sharing your
No,
expertise.
thank you. When the
And
patient, we've got one more, sorry. When the patient
yeah, one
presents
more.
AF, how long it's been. So that's a great question, and I tell you why that's a great question is that I spend a lot of time trying to decipher the onset of symptoms. So majority of the time, a significant portion they have an incidental presenting. So how was it done? Oh, it was on a routine ECG or the routine assessment. That tells you that he or she may have had the symptoms for a while. If that's the case, rate control would be the first approach, especially if they're asymptomatic. Okay, the patients I want to like refer for an invasive approach are the ones saying, oh, I was walking and all of a sudden I felt my heart racing, or I had breathlessness for the last 6 months, or I feel my irregular heart sensation for the last 2 or 3 months. Those are the ones you think, oh, they should be assessed for possible rhythm control. After rate control, when would you know? Yeah, so the outcomes are better for patients who had earlier intervention. That's why even the paroxysmal patients, you want to get them early compared to medical therapy. So we see them and I counsel them what the risks and benefits are of an invasive approach. But if they're being in a longer period in atrial fibrillation, there's a 2% risk from the paroxysmals going to a persistent state. So you want to get to them earlier. So once they hit that persistent state, the outcomes from an air fibrillation drop by 30 to 40%. So at 12 months, in someone with persistent AF, there's a 50% chance of them being in normal rhythm. In paroxysmal AF, if you do an ablation, there's a 70% or more chance of being in normal rhythm. Any other questions?
Yeah, there's one more. How to treat if you have WPW plus AF?
So I've seen this a couple of times already in my consultant career. They need an ablation. So if you have AF with WPW, what it suggests is that pathway is rapidly conducting and they're at risk of VF, right? They need to see an electrophysiologist very urgently.
I think that's all the questions we have. And thank you very much, Dr. Rathod, and thank you all of you for joining us today. I will send out a follow-up email in this afternoon, and if you have any further questions, please don't hesitate to get in touch with us. And we hope you found the section useful and relevant to your clinical practice, and we look forward to welcoming you to our future webinars. Thank you, everyone.
I can just thank the attendees for making the talk interactive. Thanks for asking questions. It really does help the speaker. Thanks.
Thanks. Take care. Bye.
Bye.